has to do with this self-administration of the drug, and that implies that you are of sound mind and body, and probably are not now on your deathbed suffering in pain, or this could be a condition such as you experience of paralysis. How does one self-administer without, if they're incapable of doing that?
You can't.
You can't. So is there a slippery slope here where at some point we say, well, today it's okay if you self-administer this, you're all right, but can we foresee a time 5 years or 10 years hence when the law would change and say, well, of course you can't self-administer it if you are paralyzed or incapacitated? So has there been any kind of parallel experience in Oregon with regard to that? And do you fear, Dr. Brown particularly, that that may be a slippery slope we take with this, if we should say yes?
I'll just answer quickly that the slippery slope argument is one that is apparent, obvious, and a concern to people, and one that's been made in Oregon for a long time. It has not materialized in Oregon. There's not been a lineup of incapacitated people or people in wheelchairs lining up to get prescriptions. Most of the people who use these prescriptions are people who have health insurance. They're people who they die in hospice or with their families. They have support, they have care, and so there's not been a slippery slope where disadvantaged or somehow, people who become, people with Alzheimer's disease, for example, might be given these things by their family or relatives. And in fact, it's again because the thing is out in the open and people have to, let's face it, I mean, you're all here because you're willing to talk about this, but death is not social conversation. It's not dinner chit-chat. But in states like Oregon, it's an open dialogue now between physicians, healthcare providers, and patients. And that, I think, can only help.
Slippery slope. I'll just be very brief. Look to the Netherlands if you really want your answer, because they have had this for a lot longer than we have in the United States. Euthanasia. I think if you really want to, Google up the Netherlands and see what's happened there. And I think your thought process worked itself right out there. And I think that's really scary.
Could I just have a follow-up on Dr. Brown's comment in her 10-minute dissertation? There is a coercion on the part of the doctor by society, by the law, that says you must certify this death according to the proximate cause of the disease, shall we say, but does not recognize that it's a medically administered death. How do you feel about that? Do you think it compromises a doctor's integrity?
Frankly, no, because it's not a medically administered death. The doctor has provided a prescription. The patient has chosen to take that prescription. They've chosen to take. The reason they've chosen to take that prescription is because they have a terminal illness.
But the cause of death is taking that medication, is it not?
All right, but then why don't doctors put double effect on the death certificate when they allow someone to die?
I don't know what that means, I'm sorry.
Double effect is when you treat someone's pain with sufficient enthusiasm that they die from it. When you give them so much morphine that it controls their pain and it ends their life. Do they put death due to morphine? No. They put death due to cancer. So that, I think, is the issue.
With all due respect, I hope that you in the audience are kind of hearing the double speak. I wrote down, this is not a suicide, was a quote I heard from my companion up here. If this is not a suicide, I don't know what it is. It's hard to really even answer that kind of twisting of, like the whole issue with the death certificate, that I'm to write down died of COPD or something when it's really a prescription. I don't see why the people that wrote this and signed it initially wanted it that way. Why wouldn't you want the truth? If there's nothing wrong with this,